everybody is trying to go indoors, but your brain, your system was built to socialize.
There is no day that AI will completely take over.
Somebody who has cancer, for example, is more likely to have depression.
Those who started smoking before 25 is different from those who started smoking after 25, because the executive functioning part of the brain, the prefrontal cortex, have not developed before 25.
The fact that the symptoms are no longer present does not mean that the illness has disappeared.
We can feel guilty that you can go to confess to the priest that you are the person responsible for the war in Iran. That is already a pathological guilt. You think it's about the boyfriend. No, surely not about the boyfriend. If the other two didn't happen, the brain would have been more resilient to contain this other one.
I know there are cases where people have some mental challenges after giving birth. I think that's where she's coming from.
These people who use holy water, we gather medications they use in mental health institutions, dissolve it in holy water, and then dispense it to the unsuspecting people. And then there is some level of calming of their symptoms. People with mental health issues are not more violent than people from general population.
In multiple ways, physical illnesses can lead to mental illnesses.
Spirituality and religion is a good coping resource. But the problem is that the same spirituality and religion may also be a hindrance to treatment.
What are the most common early signs for mental illness?
Somebody who is obviously outspoken now becomes quiet persistently. You should be able to ask questions, what's going on? It may not be New Year resolution.
I would say that somebody has recovered when they return to function, but it doesn't mean that the illness has been totally cured.
You're welcome to another deep and insightful conversation. My name is Oghenevwiere Nabena, a mental health advocate with the Mental Health Sentinel, and I'll be your host for tonight. I am super excited to have you here. You're welcome. May is the Mental Health Awareness Month, and it's an opportunity for us to take time out to focus on our mental health and total well-being. This is a safe space to learn, unlearn, and feel seen without judgment. We would like you to be very honest and open-minded. Have you ever looked at someone and you do not understand why they are acting the way they are acting? Or maybe you're watching your elderly uncle constantly missing his way home and you're deeply worried. Perhaps you are secretly drowning in deep sadness right now, but you're terrified to speak up or see a professional because you fear being labeled unstable. And you're also worried about social stigma that will ruin your family's reputation or possible marital prospects. Do you have a child battling drug addiction? Have you spent years seeking spiritual cleansing only for things to get worse, leaving you convinced that your village people are actively at work? Or maybe you are like me, who has carried around scary, unanswered stories about popular Iselu or Yaba left. If this hits home, I need you to take a deep breath. You are not alone. And this session was made specially for you. Our guest tonight is Dr. Justus Onu. He's an associate professor of psychiatry at the Department of Mental Health, Nnamdi Azikiwe University. He's also a consultant psychiatrist at the Nnamdi Azikiwe University Teaching Hospital, Nnewi, Anambra State. He is a visiting psychiatrist at the Federal Neuropsychiatric Hospital, Enugu. He has worked continuously in the field of mental health for over a decade. He has received honors from the American Psychiatric Association and the United Nations Office on Drugs and Crime. He has a fellowship on spirituality and health research at the Duke University of Divinity. Above all, he's a family man, married with 5 beautiful and wonderful children. Dr. Onu will kick off today's topic, the social climate and status of psychiatry in Nigeria. Joining him to ensure that all our questions are answered is here with 3 members in his team, Dr. Neoma, Dr. Temitope, and Dr. Obioma. Together, we are looking beyond village people because it seems like we're giving them too much credit over our mental health challenges. Dr. Onu, it is a great honor to have you and your team with us today. You're welcome, Dr. Onu.
Thank you very much, Oghenevwiere. Yeah, sorry, I told you that it's difficult to pronounce the full name, but I'll try. Yeah, I'll be shortening it. Yeah, thank you for having us. And thank you, Dr. Norma and Temitope, for joining. We're still awaiting Dr. Koye. I hope you can hear me clearly.
Yes, we can.
Okay. In the next few minutes, I should be introducing our discussion, and then we'll be handling your questions thereafter. We are going to be discussing, beyond village people, the social climate and the current status of psychiatry in Nigeria, public and practitioners' perception. Just to say that I have no conflicts of interest to disclose with regards to this presentation. Okay, so we begin by acknowledging what is health. According to the World Health Organization, they define health as a state of completeness. So in other words, they look at 3 dimensions of wholeness: physical, mental, and social well-being, and not just absence of diseases or infirmities. So in other words, if we have to have strict interpretation of this definition, we may argue that nobody is completely healthy. So that you don't have a disease does not translate to a good health. So if we are to summarize this definition, we can say that health transcends, the presence of disease or infirmities. So from the scratch, mental health is an integral part of health. In fact, in this definition, we can actually see that 2 components of health definitions is integral to mental health. The first is the emotional, and the third is the emotional well-being. So the physical health is just one dimension, but the emotional and social well-being are collective part of what the human brain can do. And of course, there is actually no dichotomy between the physical health and the mental health, because there is some level of interrelationship. Whatever affects the body also affects the mind, and whatever affects the mind affects the body. So you can see the interconnectedness of this definition. So then, what is mental health? The same WHO defines mental health as a state of well-being in which the individual realizes his or her own abilities, copes with normal stresses of life, works productively and fruitfully, and makes contribution to his or her own community. This is a very interesting definition. I didn't hear them mention the mental disorders. So they talked about basic relationships, your ability to realize your abilities in life, cope with normal stresses of life, foster some level of fruitful relationship, and be able to contribute to your community. So in other words, if you're not able to sustain some level of relationship with human beings, you're not able to contribute to your quota to your community, you may not necessarily be having any mental illness as put in the manuals for diagnosis, but you may not be mentally healthy. So you can see that this definition is very comprehensive. So it talks about your ability to realize your abilities in life, to cope with normal stress that we go through in life, and then be able to work productively and make contributions to your community. So therefore, mental health is fundamental to good health and quality of life. And it is not mere absence of mental disorders. So let us look at health or mental health as a continuum. If you draw an analogy with physical health, you remember that if you go to a hospital, they can take your temperature, and then they say your temperature is 36, 37. So in other words, it's within normal range. But you could also get to the hospital and they will say your temperature is 38. Now, the same normal temperature has become abnormal. That's what you now call fever. So let us look at mental health as a continuum. Now, the continuum theory of mental health means that all of us is in the spectrum. So at one point in your life, you may have good mental well-being, but you could also get to the other end where you have a mental illness. In between, you may have a problematic point. And we oscillate from one point, you move from one point to the other. So some people are healthy today. They can get to a problematic level of mental health tomorrow. And maybe they may even get to the extreme point of having a disorder. And those at disorder point can move to a healthy point. So looking at this analogy, it gives us some level of humility that if you're healthy today, it doesn't mean that it is must that you remain healthy all through. Things can happen and you can move from a healthy point to a problematic point, and may even get to a disorder point. But you could also move from a point of disorder to a point of wellness. So that's the continuum nature. So this diagram tends to illustrate it more. So you could be healthy with your normal functioning. At this healthy point, you're generally satisfied with life. You're happy, you're goal-oriented. But you could also get to the problem point where you have some distress, but you could still function. Then the disorder point is where you're unable to cope and you're unable to function. So that's the continuum. And people can move from healthy to disorder and from disorder to healthy point. That humbles us. So if you see somebody who is ill, the person is just on the continuum from healthy point to a disorder point. And this person can also take appropriate measures to get back to the healthy point. So that is the nature of the continuum. So let us briefly look at the evolution of mental health in Nigeria. So we divide it into 3 phases. Of course, the traditional phase before the colonial masters came, we have our own traditional ways of dealing with mental health issues. And then we have the point of transition, where we are moving from the traditional to the therapeutic. And then, of course, we have the therapeutic phase that started during the discovery of major drugs that helped us in the treatment of major mental disorders. So, of course, the traditional phase had to deal with, we have our own names for mental disorders, from different parts of the country and the different ways we were treating it, at that point. Now, the transitional phase had to deal with, of course, the establishment of the asylums. Then we have the lunatic asylums, because at that point in time, the emphasis was on taking off people who are mentally ill to safety so that they prevent them from becoming a nuisance to the community. So the treatment then was basically custodial, contain them in a space called the lunatic asylum. And then, because of course at that point there were no treatment known, so it was more of containment, so that's how of course the Calabar Asylum, the Yaba, all these asylum, they were now transitioned later to major psychiatric hospitals in the therapeutic phase. So the therapeutic phase had to do with the period where medications are available. There were advances in psychotherapeutic interventions and social ways of treating people with mental illness. So this is the point of the hospital, the community mental health services, the introduction of psychiatric department of teaching hospitals and federal medical centers, and the training of specialists to handle mental health issues. And that's the phase we are in currently. So let us quickly reflect on our topic. So what do Nigerians think about mental illness? Well, of course, our title today talks about beyond village people. So, but traditionally, many Nigerians do believe that mental illness is caused by supernatural causes. In fact, this is the most common hypothesis. And this hypothesis drives the care that people seek when they are ill. So there are these common hypotheses of evil spirits, demons, and all forms of possession. About 30% In other words, 3 out of every 10 Nigerians tend to believe this. And this is not restricted to villagers or people who are uneducated. We are talking about professors, people in different places of society. There is no limitation to this thought. So you can see a professor who also thinks that mental health issues are due to supernatural causes. Well, it is not uncommon that people will think this way because the symptoms of mental health issues may look paranormal. For example, somebody may be hearing voices of unseen people, so it becomes difficult to understand why an individual may hear voices or something. Now, but of course, we do know how people can hear voices with regards to how the brain works. So because of the nature of this and the unpredictable behavior of some people with mental health issues, it may not be uncommon that people may think this may be evil spirits. And then witchcraft causes, punishment from God, generational causes, and the village people, that spiritual attack. So this is expressed in different forms, across Nigerian society. I did some level of work as a medical officer in Delta, and in the village where I was working, they talk about spiritual arrow that are thrown to people and then cause them to go insane. So various communities in the country do have different ways they explain the same thing, but basically it's about supernatural causation. But this is a very common theory, but that's not all Nigerians believe. So let us look at other ones. So there are people who think about behavioral or individual factors. So there are this subset of people who think that it's about substance use or substance abuse that causes mental health issues. Well, there are some level of truth in it. We know that people who start using substances early, those who use it early in life, before the age of 25, because of the changes that happen to the brain during this period, there may be some level of relationship between substance use and mental health issues. But what we do know is that substance may be a cause, but most likely substance may be a precipitating factor. So in other words, this individual may have been genetically vulnerable, but the use of substance will now bring up the disease. So in other words, this individual may not have had the disease without the smoking, but the smoking may have precipitated an illness that may have been dormant. Now, there are people who still believe on personal sin or wrongdoing, and of course, stress and trauma. Now, stress and trauma in psychiatry, we do know that this may not necessarily cause the illness, but they may precipitate an episode. Now, Nigerians also do have some belief on biomedical causes or biological causes of mental health issues. Yeah, this is less common now, but if you look at when people want to get married, their family members may go to other family to find out basic history, which is the history of a mental health issue, criminality, and all forms of vices. Now, why are they doing that? Because they believe that bad behavior or mental health issues may cluster in a family. Now, families share the same gene and also share similar environment. So these people, this kind of belief lends some credence to the thinking that some Nigerians also do know that there may be genetic basis to mental health issues. This is obviously correct. For many mental health issues, genetic heritability estimates may range up to 80%. For example, psychotic disorders like schizophrenia, the one we commonly call madness, most people have genetic predisposition up to 80%. The one we call bipolar disorder is up to 90%, depression may be up to 50%, alcoholism may be up to 50%, and so on. So in other words, this belief on biological causes or biomedical causes of the disease is there in Africa and in Nigeria, but not very much. So as I earlier said, it may be demonstrated by the marriage inquiries looking for family history of mental health issues, which is a suggestion, an indirect suggestion that these people may believe that there may be genetic basis for mental disorders, which in fact is correct. Now, there is also this very common phenomenon for those of us who practice mental health in Nigeria, what we call malaria. Everything is about malaria and typhoid. So it's not uncommon that in your clinic, somebody have a frank mental health issue and they are coming with results from the laboratory that this person may have had malaria that entered the brain or typhoid that entered the brain. So this is also a very common one that comes to us in the clinic. And that's also a form of biological belief, because they believe that a microorganism may be responsible for this disease. This is not necessarily very correct, as you'll come to know that before malaria could get into the brain, it may be for like a child, but for adults, most adults who have developed immunity, they are less likely to have severe malaria in such a way that it will enter the brain. Well, and of course, if it's malaria entering the brain, it's still treatment of malaria that suffices, not a mental health treatment. Okay, so social factors like poverty and family dynamics have also been talked about as possible reasons for mental health issues in Nigeria. Now, these are people's perception. I'll talk about my own reflections about what could have caused mental illness. Now, this perception of the people may lead to the pathway to health-seeking behavior. So, how do Nigerians seek help when they have mental health issues? We talk about medical pluralism. In other words, this is typically multiple. So, but many people move from, it can be formal or informal care, but most people use informal care. And this is shaped by the belief about the cause or cost and access. So commonly, who do people go to? Herbalists, traditional healers, religious or faith-based healers. And this is greater than 70% of people with mental health issues do seek kind of help in these places. Now, why do they do this? It's because most people believe that this disease is caused by supernatural causes. And of course, faith-based help may be sought. Now, the type of interventions they receive are prayer, fasting, use of holy water. I sterilize holy water because this is a very common practice around us. And the most important thing about it is that there's some level of deception here, because these people who use holy water, we gather medications they use in mental health institutions, dissolve it in holy water, and then dispense it to the unsuspecting people. And then there is some level of calming of their symptoms. But because they do not take the adequate dosage of the drug, the illness will not go. They just become a little calm. So the family thinks that there is some improvement but this person does not return back to full functioning, which is really what people in the Orthodox institution would want, which is you getting well and going back to your full occupation as it used to be before. Now, but this person just becomes calm. He's not disturbing them, but he's unable to function in his daily activities. But everybody is happy because he's no longer disturbing them. So biblical verses, herbs, counseling, beating and chaining. We have watched documentaries about how people are beaten up in several homes, several spiritual homes. Now, the problem is that this treatment is not evidence-based, and they delay the duration of untreated disease. So people stay in these institutions 5 years down the line. And 5 years of illness is the most critical period that we should treat this individual and return the person back to life. For example, somebody who is psychosis is living in his own world. So if this person is ill for 10 years, you can imagine how the world has evolved. For example, if there were no Nokia phone when the illness started, and then 10 years down the line, people are using phone, this individual is still left at 10 years behind, so that when he's even well, the world is far, far, far ahead of the person. So that's the problem of the danger of staying in these religious places, because they delay the treatment, and then there could be harm arising from chaining. We have had people who had broken bones, or those who have thromboembolic phenomena, those who had stroke, because they were restrained in one place, and then they throw what we call embolus or emboli, which can now get to the brain and then damage it. So these are the problems of this. Now, there is also a secondary contact factor. So in other words, the family and community are chief decision makers in Nigeria. So where you go to and the type of help you seek depends on how much your family is aware of resources, because we run a collectivist kind of society such that everybody is not individualistic. Families and community are good decision makers in the lives of people around. So if they know, you are most likely to get better help. But if they don't know, of course, the help you will get may not be as optimal as it should be. So they decide they will help you seek, whether it's formal or that as orthodox care. And of course, whether you go to laboratory or whether you go to a PHC is determined by this individual or individuals. So other places that Nigerians seek help include, of course, orthodox care, specialist hospitals, mental health departments of teaching hospital, federal medical centers, private psychiatric hospitals. So in summary, one can say that it's a multiple care system, and sometimes people will combine orthodox with unorthodox. So while they go to the hospital for relief of symptoms, they also go to the traditional places to seek interventions from their forefathers and then cast out the possible cause that may have caused it. So in Nigeria, multiple care systems are very common. In other words, people can patronize the hospital and also the unorthodox care. So the typical pathways, when symptoms start, family attribute it to spiritual attack. So the first point of call is faith-based healers. If there is no improvement or violence, they may seek help in orthodox settings. And sometimes, usually, they will return to faith-based care for continuous support when they feel better. So this is commonly what we see. Now, let us look at what do other people think, like healthcare workers and maybe medical students, where the picture is mixed. The truth is that even within the healthcare system, among non-psychiatric doctors, they also have explanatory models are pluralistic. In other words, just like general population, even within the medical cycles, some people still believe that it's a spiritual attack. So, and then stigma and discomfort, persist among other healthcare workers. So they are less likely to tell you, oh, I want you to see a mental health person, because themselves they feel ashamed of saying it. They don't know how you will react. So this is really a common experience in our teaching hospitals where you can hear a patient say that the doctor say, well, go and ask your ancestors. It may be a spiritual attack or something. So that you don't know does not mean that it's not a problem. So what are my thoughts before we listen to your questions? Well, we know that mental health issues in terms of etiology is biopsychosocial. So there are biological factors, there are psychological factors, and there are social factors with regards to developing any mental health condition. In fact, it has been expanded to include spiritual. So we now call it biopsychosocial spiritual, factors that are responsible for mental health issues. The biological factors are very crucial. They give us the vulnerability. For example, the genetics, the neurobiology, the anatomy of the brain, and all that we know play significant role in the development of mental health issues. Now, both social factors and psychological factors are also important. Social factors like, things like poverty, unemployment, all the indices of social disadvantage may not necessarily cause mental health issues, but they may trigger it, in those who are already genetically vulnerable. Psychological factors are also important, like people who tend to have a cognitive bias, those who tend to attribute negative things to things or negative attribution to things are more likely to develop maybe depressive symptoms when they have life events. So psychological factors are important. And then spiritual factors, the spirituality and religion is a good coping resource. But the problem is that the same spirituality and religion may also be a hindrance to treatment. So why social support or religious support are crucial in trying to keep people mentally healthy? Religion can often be obstacles in ways that are difficult. And these conversations we may deal with as the questions come up. So thank you very much for the short reflection. So I'll hand over to Oghenevwiere for the question and answer section. Thank you.
Thank you so much, Dr. Onu. This is quite detailed and very insightful. I'm glad that you've been able to carry us through where we were coming from in terms of handling mental health issues to our current reality. I'm also glad that you were able to give us the connection between the biological and the spiritual and also social factors that may trigger mental illness. Because personally, I will pray, but I also want to get the medical point of view as partake anything that concerns my health. So thank you very much. You said something that really caught my attention. You mentioned that we need to address mental illness within the first 5 years of observing that the person, that gives you a better result in terms of recovery. So I want to ask, what are the most common early signs for mental illness in terms of the behavioral, emotional, and physical aspects that we should see and take seriously?
Okay, so thank you very much. As I said, I have other panelists, but let me start with this. Yeah. Well, it is important to know that every behavior that becomes a sign of mental health issue has a normal phenotype. So in other words, sadness can be normal, but sadness can also be a sign of a disorder. I will quickly run through some things, some questions that are thought-provoking, and then help us to judge when to know that we have a flag. So for example, when does normal forgetfulness become a sign of somebody developing neurocognitive disorder, what we used to call dementia? You know, many people do forget. But when do we now say that this person is moving from just normal forgetfulness of everyday life to developing an illness that may be an initial phase of what we call now, what we used to call dementia, but of course we call it neurocognitive disorder. So when does normal sadness become depression? When does normal, suspiciousness become a form of delusion you see in psychosis? So in other words, most things that become a mental health issue has a normal type. So when things that are good happen, we feel happy. When things that are sad happen, we feel sad. But in between, we are just okay. So when do one say that this person is developing depression? Now, ways to take a look at it is, first of all, look at the sadness and say, is this sadness distressing? That's the first D. Is it distressful? Then the second D, is it durable? Is it a transient sadness, or has it persisted for some time, at least for 2 weeks for depression? And then the third is disability. Is this sadness leading to either difficulties in your personal care, you no longer make up the way you used to make up, or you struggle to have your bath? This is personal functioning. You also look at family functioning. Are you still able to wake up early to dress your children, or you do it with difficulty, right? Are you still able to be cheerful in conversation with your spouse? Is your libido still okay as it used to be, or have you completely lost interest in those? In other words, is my family functioning affected? How about my occupation? Do I struggle to go to work? Or if I go to work, I used to calculate like a mathematician, but now I struggle with numbers, right? Or are my friends complaining that I am now a little withdrawn? So you have to check first, is my symptoms causing my normal, what used to be normal, is it causing me distress or other people distress? Is it durable? In other words, is it lasting longer than necessary? And then, is it causing any disability? And then the last question is, can anything else explain it? So if nothing else can explain it, right, one may just be drifting to a mental health condition. It depends on the type. So when you become suspicious to the point that you now lock up yourself in the door, you no longer go out, you feel your food is poisoned from your mother that have fed you for years, and all that, you may have been drifting, and now you no longer go to work because everybody talks about you in the workplace. you're already drifting into a psychotic phenomenon. We do not know which one it is until you see your doctor. Then if you used to drink, all of us, sometimes you may drink alcohol, some people may have smoked once in a while. But when do occasional use of substance become substance abuse or even dependency syndrome? It's the same thing. When there is loss of control about your initiation, how many you want to take and when to stop. In other words, it's no longer you that says, go and take it. It's the drug says, take me now. If you don't take me, you begin to shake or you begin to feel uncomfortable. The drug says how many you will take. Initially, you just take one bottle, you're okay. But after one bottle, you're not okay. You have to take a little more until the drug says, I'm okay. And then you have irresistible urge to use them. You use them despite having evidence that you are being harmed, yet you cannot control yourself. At that point, it is no longer a normal use. It has become a disorder in some ways. Whether it is an abuse or dependency, is for your doctor to establish. So everything that we see as normal, for example, even being happy. Some people can become happy excessively that they dash out everything. They come in and dash out. They can go impersonate people, claim to be the president that they are not. Dash out their phone. If you beg them for their clothes, they remove their clothes and give you. That is a manic episode. The same happiness becoming to the point of a mental health issue. So in other words, every normal thing that we feel can become pathological. Normal guilt can become pathological guilt. When you feel guilty, we all feel guilty. We can feel guilty that you can go to confess to the priest that you are the person responsible for the war in Iran. That is already a pathological guilt, and this could be in the context of a mental health condition. So the warning signs are always a departure from your norm. And then this person has a norm, but there is a departure from the person's norm. Somebody who is obviously outspoken now becomes quiet persistently. You should be able to ask questions, what's going on? It may not be New Year resolution. It may just be something going on around the person. It may not necessarily be a disorder at this point, but this person is moving from his normal point of healthy to a point of problematic point. If care is not taken, you may get to a disordered point.
Wow. Thank you, doctor, for clearing that question. All right, the next question, you touched a bit of it. I'm quite concerned because substance abuse, especially among the young, it's currently what I will call a national emergency. Having statistics from the World Health Organization saying over 14 million individuals have used drugs and alcohol in the past year, and out of every 4 users, 1 is a girl. So gender does not even play. It's not a man thing. Females are also into substance use now and abuse. Doctor, I would like you to help us elaborate how it affects our mental health, because it's actually a social pandemic as well, because we see them all around the road. Everybody's smoking anything and everything these days. So can you just educate us on how to ensure it doesn't trigger or worsen the situation?
All right, so at this point, I'll bring Temi in. So Temi, talk away so we can shed some light here.
Substances are a part of our culture. I was doing it before now, and researching, just how much we have consumed alcohol over the years and history, and it can date you back to like 11,000 years ago. It has always been present. People use them to change their states, and kind of refer to them as psychoactive substances because they can change the state of mind. And
at the clinic level, we get to see age of initiation going down to 9 years to 7 years. Initially, age of initiation was around, when I did a study in 2019, it was around, the median age was around 17. But recently, the median age is going to 12 years. So in other words, people are initiating substance use much earlier. Remember that the brain develops, there's a way the brain develops. So the very first 5 years of life is crucial. But the last part of the brain to develop actually tend to do that around 25 years. So when you start exposing the drug to the brain to pleasure, because what the drugs do, the final common pathway of whatever that excites the brain, whether it's alcohol or any other psychoactive drugs, which basically we can divide into three for clarity. The first group is the depressants, those that we bring down the nervous system to sleep. So that's where alcohol, some sleeping pills, opioids like tramadol and all that, they belong to those groups. Then we have the stimulants, the ones that keep us awake. These ones are now very, very much abused because of people who do internet fraud. Because of differences in time zone, when Americans are waking up, we are sleeping. So people need to keep awake all through the night. So that was the explosion of stimulants like mini ice, the methamphetamine, them. Those ones are stimulants because people need to take them to keep awake all through the night, maybe to catch up with a time zone different from their own zone due to their internet fraudster things they do. So that was the explosion of that. And then the ones we call hallucinogens, they alter the perception. So you can actually hear voices or see people passing even when nobody is passing, So that's how they are classified. But all of them, what they do to the brain is that they elevate a pleasure chemical called dopamine in certain areas of the brain. That's what actually people seek. That thrill, that pleasure, that's the addictive property. Now, but this same dopamine that is important in one part of the brain as something that gives us pleasure, also is that in another part of the brain that actually causes us to begin to attribute unusual importance to things. So, for example, a lizard comes to your room. Normal people will just say, this lizard missed the way. But if the dopamine is elevated in certain area, you begin to say, they don't send them to me. So that's how you begin to misinterpret something that is not of importance becomes of importance. So you are walking on the street, you think everybody is talking about you. Meanwhile, nobody is really interested in you person. So you see the connection between, in one part of the brain there is pleasure, in the other part of the brain is a different thing happening. So that's why substance use is very closely knitted to development of other mental health issues. But substance in itself can also be a mental health issue. Of course, when you have an abuse or dependency syndrome, they are also treated within the mental health space because they are classified as mental disorders in the diagnostic manuals that we use in medicine. So that's how they are related. Yeah, thank you.
Thank you, Dr. Onu. Thank you. If you're just joining us, you're welcome to Beyond Village People, a conversation brought to you by the Mental Health Sentinel. Our chat room is open for your questions. We have a panel of professionals ready to answer them as time permits. Please stay tuned because it's getting more exciting. So, Dr. Onu, we've addressed substance abuse, and you've raised how initiation age has dropped drastically, meaning the younger ones are getting substances into their system, which is also a factor leading to some mental health disorder. So let's move to the elderly. So recently I heard of an elderly man over 70. He started acting off and he was unable to find his way back home. And like you also pointed out earlier, there's always a cause or a spiritual aspect to it. And in his case, his kinsmen came together and they finalized that he has been a trouble to the family. So it's his sins that he is paying for. All right. So I want you to help us demystify the story by telling us, are there mental conditions that are common in the older people, like the grandparents? Do they is their age a factor?
Okay, so Norma, you could start the conversation. I'll add my own thoughts to it. So Norma, go on.
Okay, thank you, sir. Thank you, everyone. So, yes, actually, there are some mental illnesses, just like you had asked, that are more likely to be seen or to be found in people of certain ages and whatnot. So, it is not an unusual thing for an elderly person to suddenly start maybe losing their way, misplacing things, amongst others. No, we are not going to blame this on village people or their sins. Just like how we have mentioned that there are different kinds of mental illnesses and the origin is multifactorial. That is to say, there are different components that bring about the commencement, so to speak, of a mental illness, which include the biological aspect and the social aspect. Now, and these people who are elder in age alone is the factor. The older one is, the more chances they have of being predisposed to certain kinds of mental illnesses, the most common of which is dementia. In fact, some will argue whether dementia is a mental illness or whether it's a neurological illness, but either way, they are mental manifestations, they are behavioral manifestations of illnesses like dementia. There are even some other illnesses as well, things like Parkinson's disease could also have a mental component to them. So yes, that biological factor is there. And then when you now consider the genetics, the predisposition to it, whether there are people in their lineage who have had such mental illnesses, of course, age again being one of the more topmost triggers. I'm trying to find easy ways to explain this. Then, of course, you look at their psychological factors, their social factors, the amount of support that they have. So yes, it is possible that there are some mental illnesses that are more common, that come up more in the elderly people as opposed to in the younger people. And that's one of the reasons why one needs to be careful with elderly people. It's not an issue of maybe just abandoning them or leaving them to be cared for by people who may be young, who may not be as exposed, who may not have as much information, or in places where, like you mentioned, in the village, the superstition may be even much higher. So it's important to actually keep an eye on them, to know that with rising age, there is a chance that they are more likely to come down with some of these mental illnesses. And when we notice a departure from the norm, when we notice a change in behavior, when we notice things like them losing their way, things like them starting to talk to people that nobody else can see, or to see things that nobody else can see while they are fully awake. All of these are things that one would point and one would realize that could be pointers to the illness and refer them to, bring them to mental health practitioner.
Yeah, thank you. Thank you, Neya. So just a few addition to that, just to say that memory is a very important thing we talk about in the illness we call dementia. Dementia is actually common in old age. So in other words, when people are getting old, they are more likely to have brain loss. And this brain loss can come as a form of memory loss. So somebody may actually be in the house and say, oh, I'm not in my house, so please take me home. Right? Mm-hmm. So you'll be thinking that this is, but it's just about the fact that he has forgotten. That's why he will urinate on his bed, because he has forgotten the toilet, and all that. So dementia comes with memory disturbances. It comes with loss of function and, of course, behavioral changes. So the person may shout, may even hear voices you think is mad, but no, it's not in the context of the other form. It's just in the context of the dementing illness. So that's an important thing. So the other thing I want to add about the elderly is that the elderly are also predisposed to depression. And when they do, they may make confessions that are not. Remember what you call emptiness syndrome. As you're getting old, your children are gone, your spouse may have died, so you are isolated, and to a large extent, this is a recipe for old age depression. Meanwhile, there are comorbidities, hypertension, diabetes, plenty medication at this age. So the elderly may even go on, when they are depressed, to make confessions like they killed people or that they were witches. They never were witches, but they just have maybe guilt from depression, and they may make confessions that are not true. And then they will bring them out to the market space to, maybe to stone them that they are witches or something. So I remember a story from my village. I went home and they told me that one woman confessed that a young boy slept with her. So they were going to take the deity to swear or something. So I told them no, that they should give me this woman to treat, that I'm sure that this woman is sick, that they give me the woman to treat. Maybe after treatment, they should ask her again whether she really did. Because when I asked them, how old was this child? So they found out that this child was around maybe 8 years as of the time the woman was alleging that they had sexual relationship. It was almost impossible for that 8-year-old child to have sex with an elderly woman at that point in time. So I told them, see, this story is not tying up. They should give me this woman may be depressed and maybe now having guilt. She may have had feeling for this young boy, but now she's confessing as if to say it is here in life. But when she's now depressed, the guilt will be like she have killed the person. So this is one of the things that happen in old age. They now say old witch, and all of us will participate in stoning them. So these are ways that mental illness can happen. There may be people who commit bad things and confess, but we should also look at those subset of people who may have had a mental health issue. Yeah.
All right, Dr. Onu, thank you. We lost you for a bit, but I think we've gotten the message. We've seen these signs. We've acknowledged that old age, substance use are also triggers to having some mental disorder. So can you please help us with the first practical steps that we can take? What do we do at home? Where do we go to first for professional help in Nigeria?
All right, so services are available in our different cities, so of course we must acknowledge that there is limitation with regards to mental health access in Nigeria. So normally the first point of call should be the primary health care centers. But of course we know that the training is not well developed for mental health care in many states. But there are some states that are, for example, like Lagos State and Ogun State, they have their primary healthcare workers were trained in recognizing mental health conditions and even giving some form of intervention. Now, but where it is not available, just know that ask your nearest health practitioner. There is always a mental health department in any teaching hospital. No matter how small the teaching hospital is, there is a mental health, because you can't train anybody in medicine without mental health. So every teaching hospital, we have one. Most federal medical centers we have. And then every geopolitical zone have a psychiatric hospital. And there are many private psychiatric hospitals too, depending on what help you want. And then there are online facilities like suicide prevention program. It's called Supine.
Supine, yes.
Supine. Yeah. So these are online resources you can use, to get some level of intervention, and eventually they link you up to a healthcare practitioner who is able to take it on from there. There are also some NGOs working on substance use problems. So you find any local one in your community, they will give you some level of counseling and can escalate the issues to appropriate quarters if there is need, because they have the channels. So, of course, we still have to, the church is not like a space for treatment for mental health, but we know that they form a very big support base for every community. So your church people look out for you, and social support cushions the effect of stress. So they may not necessarily treat mental health issues the way we do, but there surely are good, important cushion measures, we can utilize to foster some level of social support within our system. And of course, when we pray, we gather some connectedness to God, and this also have a way of relieving our anxieties. But they should not primarily be where you will seek help in terms of when you're already broken. You will need additional help while you use these other resources to cope within your community. Yeah, thank you. Mm-hmm.
Thank you very much, Doctor. Thank you so much. Is full recovery possible? Before you take this question, please, if you have any questions, we are open to take them while we are going through the questions we've gotten already. Is full recovery possible, Doctor?
just the way we have discussed mental health as a continuum, we may look at recovery as a spectrum. So because when you say full recovery, people may start to think it's like malaria. And a lot of times you do see people that say, oh, I had a mental illness some time ago and I'm completely free and I'm completely fine. However, that's not how we measure recovery. So there are a couple of things that we look out for when we start treatment for mental health problems, and it differs from problems to problems. For example, for people who have much more externalizing illnesses like psychotic illnesses, of course you want the person to be free from those things. If somebody has lost their function, you want them to gain their function back. So it's kind of a balance between the absence of the symptoms or the remission of the symptoms and then the improvement of function. So if somebody used to hear voices, used to be very violent, used to not care for themselves, was a picture that the community calls madness, and now they don't have those things anymore, but they are not functional. The community may say, oh, he has recovered, but his psychiatrist is still looking for that function. Is this person able to walk? Is this person able to contribute? Remember, the definition of mental health says that an individual is able to contribute to his community. So those are some things that we look at in terms of recovery. So, and then even for a lot of mental illnesses, we describe them as chronic. Some of them are relapsing. This is because the organ that is involved, my chief will always say that the number one primary criteria or criterion for developing a mental illness is the possession of a brain. So the organ that is primarily affected, the brain, is, still being studied, still being understood. So a lot of the illnesses are chronic. Once there's been an injury to the brain, recovery is not something that you can predict. And so we used to have this rule of thumb that if somebody comes in with like a psychotic illness, for example, some people may have that episode, go through treatment, and then you never see them again and they are good. And then some might need to receive treatment for some time and others for a lifetime. But right now, the rule is treat everybody and continue seeing them. So a lot of times when symptoms have, calmed down and somebody has recovered, in quote, we still say, oh, come back to the clinic by so time. Still continue to take your medication, because we are very invested in the long term because it's a chronic illness. So the fact that the symptoms are no longer present does not mean that the illness has disappeared. So I would say that somebody has recovered when they return to function, but it doesn't mean that the illness has been totally cured. Also, there's the matter of response, how quickly people respond to treatment, how quickly symptoms disappear. This is usually affected by different factors that come into play here. How long was this person ill without intervention? What is the social support that is available to this person? What is the socio-economic status of this person? What is the family situation like? Does this person have a job and things like that? Those are the things that affect response, which ultimately plays a part in recovery, because if these factors are not in place, the person is likely to suffer a relapse even after a seeming recovery. So I hope I've been able to, make some sense of that.
Yeah. Thank you very much. Yeah, thank you. So just to add a few things there, the point is that the type of illness determines what we think about. Yeah. So people go through depression and they can fully recover. So as she's saying, cure is different from recovery. It's just that your symptoms are not there and you have returned back to your baseline functioning. That's when we talk about recovery. But that doesn't mean a cure. Like a cure means you don't need your medication again. No. With the most mental illness are chronic, so you can get well, fully well with your symptoms resolve, you're back to your work, but you still need some level of intervention and follow-up, to keep you well. That's to maintain your being well, because we may leave you and then after some time you may have it again. And the more you do have it, the less likely the chance that you will fully recover will be. So we just want, after the first episode, we don't want a second one. So we want you to remain well, but we may have to be following you up for a very long time. And this is not far from every other illness. In medicine, we used to say, how many diseases are curable, really? Less than 35. So if you have hypertension, you control your blood pressure, but you remain on your antihypertensive to keep the blood pressure the same way, right? Same thing with diabetes. If you take your anti-diabetic drug, your sugar will be controlled, but stop taking them, it will shoot up. The same thing with mental health issues. Yes, thank you very much. Yeah, well, there is a question on the chat.
Yes.
So you may have to take a look at it. Yeah.
Yes. Okay. The first question, the listener said, how can one treat or manage mental, I think, illness from marriage or childbearing? I know there are cases where people have some mental challenges after giving birth. I think that's where she's coming from. How can we manage that?
All right. So the pregnancy, having a baby is a good thing, right? So, but many people think that developing a mental health issue have to be a negative experience. It doesn't necessarily have to be. For example, having an adjustment problem, just getting married, having to wake up and cook for a man and wait for him to come back may become, even when marriage is something good, may become a stressful thing to somebody who didn't prepare for that. And that could tilt you from a point of normality to an abnormality. The same thing with pregnancy. Pregnancy can be desired, looked forward to, right? But after delivery, there are, of course, hormonal changes that will occur. And also the nature of support you get from your spouse. Remember, the baby tends to sleep during the day and wake up throughout the night. So there is a possibility that this woman may be deprived of sleep. And sleep deprivation is a very common reason why people develop a mental health, or they can precipitate a mental health issue. So first, the hormones go haywire, so it can be a risk factor. Then the pregnancy, the delivery state, or the child caring practices, though we do have our mothers come for Mogo, but it depends on the much support the person gets from mother and the husband. So people may develop any mental health issue after delivery. They may also have had a mental health issue before delivery, but because of the stress of delivery, they may now activate it. Yeah. So either way, we don't look at it as different. We look at it that a line has been crossed. So the doctor just takes a look and say, oh, is this person having a bipolar depression? Is he having a psychotic episode? They'll still treat it as they would have done if you were not pregnant. But they make further consideration, which is you're breastfeeding a child. And then, so because there's another person there, they will have to take into consideration, with the drug I'm going to give you be expressed in the breast milk so that it will not affect the baby. These are the considerations of the doctor, but the treatment is essentially the same. This consideration is just because of the third party, which is the baby, and all that. They also want to know whether your thoughts are harmful to the baby. Maybe some women will be depressed and they think that what they are suffering, and they don't want their child to suffer it. So they may commit what they call altruistic suicide, like homicide. They can kill their child, not because they hate the child, but they don't want the child to pass through what they are passing through. And ultimately, they may even kill themselves afterwards. So that's why the Nigerian constitution tends to recognize neonaticide, those who commit murder after delivery within the first month. They normally tend to give less judgment, maybe manslaughter, or may even discharge you, based on insanity plea or something. So that tells you that there are peculiarities. So the mental health issues in terms of treatment is not different. We just consider the mother and the child and other circumstances of childbirth. Yeah, thank you.
Thank you, doctor, for breaking that down and clarifying it. The next question is asking, are there any measures we can take when we are young to have a better mental health as we get older, or to prevent mental illness? Yeah.
Thank you very much for this question. Prevention is surely better than cure. In fact, the recipe for good health is actually in the very first 5 years of life. First of all, the in utero, when people are still in the womb. So far away from the one we begin to see them later in adolescence. It's actually what had happened early in life. So for women, be very, very careful about your pregnancy. Go for your antenatal. Make sure you deliver in a place you can have good care. Because anything that happens to the baby's brain early in life, you are just waiting for later development when the stress is overwhelming for the person to begin to fall out the other way. So good mental health actually starts from good obstetric care and good perinatal care. So the pediatricians and the obstetricians are the most important people with regards to protecting, safeguarding the brain. Brain that is well nurtured, good nutrition during pregnancy, prevention of malaria, vaginal bleeding or antepartum hemorrhage and the rest of them. During delivery, the person is delivered soundly, no asphyxia. The baby is not being beaten to cry. Because once that happens, there is already an insult to a brain that is developing. So when this brain comes to adolescent and then he fails WAEC, you think it's about the WAEC. It's not about the WAEC. We call it multiple hits hypothesis. So the first insult was in utero, the child was malnourished. The mother was not eating well. So the brain was insulted there, but the child endured. Then the second insult was during delivery. It was delivered at one birth attendant who didn't take all precaution, and the child did not cry till 5 minutes after. The brain endured it. The pediatricians were able to save the person. The person continued to live. Then somehow, in early adolescent, 21 years, the boyfriend left the person. And then the person breaks down. You think it's about the boyfriend? No, surely not about the boyfriend. If the other two didn't happen, the brain would have been more resilient to contain this other one, right? So that's why we don't reduce it to, because the boyfriend left, that's why he killed himself or have depression. Surely not. It may not be that simplistic. So preventing mental health starts remotely, from good obstetric care to perinatal care. So people should be able to guard their pregnancy and their delivery, make right choices at that point. Then early childhood, a stimulating home, a home that is free from abuses, whether physical or verbal, just growing up in a good neighborhood where he's not exposed to smoking before the age of 25. Now, this whole thing protects your mental health. Then, of course, there is also the factor of the gene. The gene gives us our resilience. So there are some people who inherit such gene that no matter how you beat them, they stand. There are other people who, where you beat a little more, they break. Others are just like vegetable, a little stress, they break down. So that one we cannot change. But there are modifiable risks, which is good antenatal, good labor delivery, good nurturing home early in life, prevention of substance use before the age of 25. I keep mentioning that it's very crucial. Those who started smoking before 25 is different from those who started smoking after 25, because the executive functioning part of the brain, the prefrontal cortex, have not developed before 25. So you can't reason well. So if you are speaking with the person who started smoking before 20, he will tell you that that's the best thing that have happened to his life. But somebody who started after 25, one day we just say, this thing not they benefit me, make I just stop it, because his level of development have reached the point of appraising himself, abstracting, and all that. So he's able to make the judgment and say, but the man that started before has been feeding himself with pleasure. So that other part becomes virtually unresponsive. So the part of the brain that is supposed to apply brake to your behavior is sitting like a stupid thing. So your behavior is uncontrollable. So that's why these people don't reason well. So good neighborhood, all this iodine supplementation, the little things they do to our food are all ways of preventing mental health issues remotely. So we are talking about prevention, not treatment at this point. And these are the various points: good school program, mental health awareness in school, exercise, brisk walk exercise, at least lasting up to 30 minutes and above, done about 3 times and above it's relaxing and also improves your mood. So these are things we could do to improve the possibility of our well-being in future.
Thank you so much, Doctor. The next question: can one sickness lead to a mental health issue? The person is giving a story of a lady that had diabetes over the years, and she noticed that she started talking to herself. Yeah. So can a mental,
yeah. So,
any medical, other illness, sickness lead to mental illness?
all right. So, Norma, please go on with the answer.
Okay, thank you for that question. Now, as to whether a sickness, whether a medical sickness can lead to a mental illness, yes, there are some medical illnesses that can lead to mental illness. Now, we've talked about the biological component, the psychological, the social component. You find that we may end up frequently coming back here when describing what is going on. And in the biological component, let me bring this down and bring it down to the simplest way I can put it. Oftentimes, one common thing that we hear about beyond infection, staph infection, that's one thing that, the layman talks about a lot. There's another thing that they talk about very frequently, which is hormonal imbalance. You keep on hearing people talk about hormonal imbalance and buying all sorts of concussions and herbal drugs to treat hormonal imbalance. Now, for mental illnesses, they are not regulated by hormones, but they are also regulated by some chemicals in the body. So just the way we have hormones in the body that regulate some functions, there are chemicals called neurotransmitters in the brain that regulate other functions. And when there is a problem with the levels of these neurotransmitters, and earlier Chief had talked about dopamine, that's one of the neurotransmitters. When there are problems with the levels of these neurotransmitters, a mental illness can, arise. So in the same way that you have that, and you have different organs interacting with each other in the body and playing a role, that's a similar way in which physical illnesses can, like medical illnesses, when I say physical illnesses, I mean medical illnesses, can bring about some changes in the levels of these neurotransmitters in the brain. Some common ones, one very, very common one includes something like thyroid disorders, goiters. Those are some of the things that can bring about mental illnesses. There are quite a number of them. Now, it can happen in different ways. It can be a situation of a medical illness bringing about a mental illness, bringing about some changes in the body that will bring about a mental illness. It can be the medical illness affecting the levels of the chemicals in the brain. It can be the medical illness affecting the way the person takes care of themselves, takes care of their environment, and even affecting the way that they respond to stress, changing their mood. And so this can now in turn bring about a mental illness. That is by their response to the stressors, because stress is one of the things that can trigger, so to speak, a mental illness. But if they're already weighed down by a physical illness, somebody who has cancer, for example, is more likely to have depression. They are more prone to it. They already have things that are weighing them down, things that, are weighing heavily on them. They are very sad. So their resilience is not as much. That's an instance. So that's one way in which you could have a medical illness bringing about a mental illness. Now, this issue of diabetes was diabetes that was given in the example.
Yes.
It's a very interesting one, because the person could even be, if it's something that happened in a short term, what we call an acute thing, a matter of days or weeks, it could even be that the person does not even have a mental illness at that point. It could be the diabetes directly affecting the brain. When the sugar is very low or very high, it can affect the behavior, it can affect the brain. So not necessarily bringing about a mental illness, but it can bring about some mental symptoms that may make you think that this person has a mental illness. Someone may be low on sugar, even someone who doesn't have a diabetes, regular people. And then after a while, they are not coordinating well. You ask them questions, they are saying something else, they are feeling dizzy, they are falling. These are behavioral symptoms that one could possibly attribute to a mental illness. I don't know if you're getting what I'm saying. So in multiple ways, physical illnesses can actually, they have a relationship, there is an interplay that can lead to behavioral symptoms, that can lead to mental symptoms, and that can actually lead to mental illness. And at the same time, mental illnesses themselves can make one even more likely to come down with some certain physical illnesses. Because with mental illness, you're probably not taking care of yourself the way you should be. You're probably not eating as well. You're more prone to malnutrition. And then some things that your body should be able to defend normally, like your antibodies and all that should be able to protect you from, because they are depleted, your body's defenses are not protected, and then you now come down with a physical illness. So yes, you can have mental illnesses bringing about physical illnesses, and you can have physical illnesses bringing about mental illnesses. It's all related. And let's take us a little bit back to the WHO definition. That's why in the definition of health, you see that mental illness is present there, physical illness is present there, because they all affect each other one way or the other, including in how people actually look for treatment and respond to treatment.
Yeah, so thank you very much, Norma, for that. So there is no separation between the brain and the body. So they are the same systems. So one can affect the other, and the other can as well affect the other. So there is no dualism. We say there is mental and there is physical. They can always interact in some ways. Yeah. All right, go on, Oghenevwiere.
Thank you very much, Temitope. We have limited time. Someone is raising a hand to ask questions.
Okay, but there's somebody who asks about the difference between a psychologist.
Okay.
I saw something like that. Yeah.
Yes,
so
what's the difference between a therapist, psychologist, and a psychiatrist?
Okay, so first of all, so it's important to draw distinctions so you know what you are looking for. First, let's say that a psychiatrist is a medical doctor, primarily trained as a medical doctor, but of course there are different specializations in medicine. So this individual are first doctors, right? That's a psychiatrist is first a medical doctor, has gone to medical school, become a doctor, then go on to postgraduate training to qualify after about 5 to 6 years to become a psychiatrist. That's one. A psychologist is a field in social sciences, and this field is actually quite diverse. So you may have educational psychologists, industrial psychologists, but the ones that work closely with psychiatrists are called the clinical psychologists. And that is like a second degree. So you would have got up to master's and PhD in specializing in clinical psychology. So a psychologist, of course, if you go to universities that are in other departments that are not anywhere near the medical school, because they are not the same. But if you want to specialize in clinical psychology, which is like a second degree, don't do it from the scratch. So when you do your psychology, you do educational, industrial, and all forms of psychology, military, and the rest of it. But for those who want to work closely with the psychiatrist, they will have to do clinical psychology in master's and PhD to become clinical psychologists. With that, they have some exposure in the hospital. But when you do your psychology, there is no exposure in the hospital per se. In terms of you may go on one week or thereabout to know that there is a specialty called clinical psychology. So these are not medical doctors. So in other words, in many countries like ours, they are supposed to work hand in hand with psychiatrists with regards to psychological interventions. They are not primarily licensed to prescribe because they are not clinicians. But of course, in some countries, they may give some medication based on some other further trainings. So for you to be a psychotherapist, you can be a psychiatrist or a clinical psychologist. You have just undergone further training on basic therapeutic interventions. So a psychiatrist may also be a psychotherapist, and sometimes a psychiatrist may not have interest in psychotherapy. He can refer his patient to a clinical psychologist with basic, but he will of course state what he wants the psychologist to do at that point in time. And sometimes some people may also go to a clinical psychologist for issues, right? But if this person will require medication, the clinical psychologist will always say, oh, you may need to see a psychiatrist in that regard. So I guess that's how to know the difference. Psychiatrists are clinicians, are medical doctors with further specialization in psychiatry. Psychologists are trained in their own way, but if you are thinking about clinical psychologist, it's a second degree course. It's not done at a first degree. So you have to take master's and PhD in clinical psychology. Then you work in closer relationship in the hospital. And therapists are clinical psychologists trained for psychotherapy and psychiatrists with special training in psychotherapy. But psychotherapy is core training of psychiatrists. So many psychiatrists are able to give basic psychotherapeutic interventions. All right, thank you.
Dr. Onu, you're on fire. Thank you so much. Thank you, Dr. Temitope. Mr. Johnson, can you unmute and ask your questions? Please make it brief. Thank you.
Okay, thank you very much. I believe I'm audible there.
Yes, we can hear you. Go ahead.
Professor, I must thank you very much for this opportunity to attend this webinar. Secondly, I must also let you know some few years ago, I had an opportunity of bringing someone to Enugu who requested that he needed to see, he used the word in quote, brain doctor. So I went to a doctor in an association hospital who now contacted another in your hospital, I think in New Haven, if I'm correct. And then that doctor examined this patient. And after a while, we were asked to buy 3 injections. So I bought 2 from one of the pharmacies in New Haven there, and then went to meet him back. He was given the treatment over a period of time, and he returned back to Delta. But after some years, we lost that fellow. And what I could say, or what I could see from there, is that the access to psychiatrics or neurosurgeon, you will call them in your field. Yes.
Neuropsychiatrist, yeah.
Yes, neuropsychiatric. To see them, it appears as if they are scarce. Like you said, they are in teaching hospitals. Is the treatment affordable so that one can travel from anywhere, the way our people go to overseas for medical tourism, whether they could come from different places to visit your hospital? That is one question. Is it affordable by the average Nigerian? 2, can you, what you were saying, I'm being mesmerized. I'm not easily carried away with certain things, but today's teaching is more. It's something that I want to, if this could, we'll have a part 2 of this. These are the 2 things I put before you. Thank you very much.
Thank you.
All right. Thank you very much. Yeah. So first of all, I must share with you, I understand that part of access. Truly, there are about 300 psychiatrists, covering Nigerians. So it's almost one psychiatrist to about 1.5 million of Nigerians. So you can see that the ratio is quite poor. And as I speak with you, we produce many and they leave. Yeah, so for my team, we are 4. 50% are now in UK, 50% in Nigeria. And the 2 that are still in Nigeria, we're not sure we stay for long. So the point is that it's difficult, but some government agencies are trying. So the WHO produced a manual called Mental Health Gap Action Intervention Guide. It's a way of trying to introduce like 9 priority mental health conditions to primary health care settings, so that CHOOS can be trained on using what they call task sharing and task shifting strategies to be able to recognize and give some intervention. So mental health the treatment is actually affordable because you are not charged differently from what you are charged in other government hospitals. In fact, if you go, it may just be 1,000 to see a doctor. What is expensive is now the medication, but it's not even as expensive as medications for cancer. So wherever you are, there is always a mental health person in each state of the federation. Now, but some states have it good, like Lagos. If you go to primary health centers in Lagos, you should be able to access mental health service because they have trained their primary health care person. So if you're in the corridors of power, our team here, we are always there to train people, to transfer expertise to lower levels of healthcare workers so that they'll be able to identify using the WHO tools and also give interventions. Nurses can actually give medication using their standing order. They treat fever, they treat malaria. They say if somebody have cough, ask this question. They call it standing order. So the WHO have also provided what looks like a standing order for primary health care. So ask this question. If it is here, ask this one. If this one is there, is depression, do this, do ABC, and all that. So the WHO provided such a guide. It is just for states to integrate them into their system. I mean, it will be less stigmatizing because where you're going to assess care for malaria, you're also going to assess care for mental health issues. So nobody knows what you're coming to assess care for. So, and it's closer to the people and all that. But every state, for now, at least, do have at least one psychiatrist. So I know that there's one at FMC in Asaba, and there could be one in Abraka too. So there is no place you will not get at least one. But some states obviously do have it better than the other. Yeah. Thank you.
Thank you.
For the other one, it depends on Oghenevwiere. If Oghenevwiere invites us back, surely we'll be back to give this education again.
We would love to have you. We would love to. We've actually exceeded our time, but I'm enjoying this session, and I know a lot of the participants here are enjoying what they're hearing. So I cannot just stop at this point. We have another interesting question here. They say, what advice would you give to a lady that has been married for over 20 years, but she's depressed and no longer wants to pay attention to herself, her children? Nothing seems to interest her anymore. Nothing seems to interest her anymore. She's depressed. What advice do you have for her?
Okay, just to say, that of course, depression comes with two cardinal symptoms, which is sadness or low mood, and then loss of interest in activities you previously enjoyed. One of these must be present for us to say somebody have so you have already mentioned two. The person is sad and the person have lost interest. So those are the two cardinal features of depression. The other ones are changes in appetite. So the person may overeat or undereat, changes in weight. Some people will gain weight if they eat so much, or they may also lose weight if they don't eat at all. Changes in sleep. They can oversleep or they don't sleep well. But the typical depressive sleep pattern is early morning waking, like 2 to 3 hours. You wake 2 to 3 hours than your normal waking time. And when you wake up, you feel unrefreshed. So other things are self-blame, poor concentration, anxiety symptoms like fearful anticipation, guilt, thoughts of hurting self, and even actually doing that and the rest of it. So if these things are present, the person have met the criteria for, and if it has lasted up to 2 weeks and the person is no longer functioning in any of the 5 domains I mentioned or 4, so that person have made the diagnosis of a clinical depression. So it is treated. I'll just advise, I'll not tell you maybe go and buy this medicine or do this and do that. I'll just request that this person gets to seek professional help. Just meeting to see a psychiatrist in any of the centers and talking about the symptoms may help the person know what level of diagnosis to ascribe. And then the treatment options are many. The doctor will discuss the options are available, and then the patient will have what they call shared decision making about the one the person wants to choose. And the doctor will support you to navigate that. And once your mood is restored, your ambition comes back again. And that's really how it is. Yeah. So that's the advice I will give to see a clinician, a psychiatrist in their neighborhood. It will be useful. Yeah.
All right. Thank you so much, Dr. Onu. Thank you. I would like to also know if the people with impression of they are scared of taking medications, because you mentioned medication last, because they are scared of the side effects. And also people have this perception that the facilities are, they don't get the service that they need, poor treatment. Can you help us just address the concerns? What are the
Okay,
rights
so
of patients? What can their family insist on when they get there?
yeah, that's okay. So just to say that every drug have its own side effect. The duty of the clinician is just to explain to you what to expect. But life is about cost-benefit analysis. You do what's the cost if I don't get treated? So I feel sad, I'm unable to walk, and that I may even hurt myself. Depression is such a suffering that one thinks that dying is a better option. Most sufferings of man, when it is relieved, like for example, things like pregnancy, when you deliver, you want to take in again. But the suffering of depression is such that one wants to take his life. That's not very simple, in as much as the person looks well physically, but that suffering is severe enough. You can judge it by knowing if somebody says that death is a better option. That tells you the level of suffering. So it's about cost-benefit analysis. So paracetamol, if you read the side effect of paracetamol, you may never take it. If you know what it can do to your liver, you may never take it. So the medications they use in mental health is not different from like people say you're taking psychiatric drug. There is no psychiatric drug. It's just the same drug produced by this different companies. The same company that makes paracetamol also makes a antidepressant or something. So it's not special in any way. It's just that it works maybe on the brain and brings some changes in that regard. So, but treatment is not only about medication. As I say, treatment is also biopsychosocial. So if you go to a doctor, he will tell you, oh, see, at this level, we use psychological treatment and social. But at this level, you will need medication. He will give you the reasons why you will need medication. In addition, the psychological and social is always there. The addition of medication may or may not be there. It depends on the level or severity of your illness or the type. There are some types that psychological and social will not work. You will require medication. Your doctor will tell you that. Now, what do you expect? You have every right, like every other Nigerian. You have the right to demand for your diagnosis, the medications, the name of your drug, the right to be treated as a person. There is no difference between, you and other other people who seek help in the facility you're coming to. And the situation of the hospital is just a reflection of the country. Not necessarily that if you move to a mental health facility where the healthcare system is strong, it will be good. So the situation is a reflection of the country, not necessarily about it is inherent that wherever they treat people with mental health issues will be somehow. No. If you go to our hospitals now, they are better. So walk into Aro in Abeokuta or Yaba, you see it's a very nice facility. It's no longer as bad as it used because of probably the government trying to update the facilities. So it's not different. You have every right like every other Nigerian. But of course, remember that some mental health issues may deprive you capacity. Capacity is your ability to make an informed decision. So because it can, sometimes the doctors can override that, especially when, remember, as a child, your parents take decision for you because you do not have capacity. So mental health issues can also deprive your capacity, and then you can be forced to have some treatment because at that point in time, they're acting in your best interests. And then our culture is collectivist. So in other words, we are not like individualistic like the Europeans. So you may go and be ill and say you don't want to be treated, they'll let you go. But in Africa, your family will say, Biko, inject himo, and they can give the consent. So that's a collectivist society. And then we listen to that because that's our culture. So sometimes the society will even bring somebody, a community, villagers can bring somebody and say, doctor, we want him to be treated. And of course, if you send him home, they may stone him. So you have to keep him. So these are just the cultural things that we take into cognizance in our practice to accommodate our culture. So the mental health can deprive you, so we can treat you against your wish, but that's not the primary. Once you have capacity, nobody treats you against your wish. They always give you your decision or give you the information, then you make a right choice. But when you are deprived of your capacity, the doctors can actually keep you from the mental health law, actually, some level of involuntary, but nobody have any right to change you So there is the provision. There is no provision for chaining, but there are some provision for seclusion. You can be taken to a room, a room that is safe when they consider that you could be dangerous to self or another. But chaining is outrightly banned in our mental health law. So nobody have any right to put a chain on you. But there can be restraints on you, but these restraints are prescribed by the doctor. It's not just anybody that comes, we give you. And that restraint must not be chained. It can be a strap or something else. There are well-designed restraints that can be used to restrain a patient that is violent, but not a chain. Yeah, thank you very much. Yeah.
Thank you, Dr. Onu. Thank you. We cannot thank you enough for this information we're getting for free. Thank you so much. I really appreciate. Okay, suicidal thoughts is becoming very rampant in our economy in Nigeria. The thoughts are not just for adults. People jump into third million bridge and all that, but it has also moved towards the younger teenagers.
Yeah.
And parents are worried, teachers are complaining. What can we do to help the little ones? What can we say to them? What are we not allowed to say?
Okay, so thank you very much for the question on suicide. Yeah, suicide is actually very common among adolescents. In fact, one of the commonest cause of death among people who are in the young from adolescents to young adults, yes, is commonly maybe road traffic accident, then followed by things like suicide. So suicide is quite common in this population. Now, there is a way to understand suicide. Suicide, 90% of suicide is in the context of a mental health condition, but not all suicide is in the context of a mental health condition. Right? So there is this 10% of people who may commit suicide by impulsivity, like, something just happened and then they take a drastic decision, right? And then they could hurt themselves. They didn't necessarily think it through, so that one is impulsivity. This individual just acted before thinking and then it led to their death. Now, but majority of the suicide actually come planned over time. And this is where, if we can prevent 90%, which is 9 out of every 10, it becomes a good thing. Many people that will commit suicide would have voiced it out to one person or the other, but will not take them seriously. So this avenue becomes a good point to educate us on what we call the red flags for people that may die. For us clinicians, we know that people commit suicide after coming to see you, after coming to visit you in the hospital. They have actually come to see if you can save them. But you fail to ask the simple question about what they feel about life. We think that when we ask questions about what they feel about life, that they will go and do it. No. The individual is actually waiting for somebody to ask him or her. But the society fails the individual by not asking. So the individual goes home to commit it. So it is a fraud in psychiatry. There is no psychiatric resident that we all know that a patient cannot pass. And you will not ask the person, have you ever felt that life is hopeless? If you ask that first question, if he says yes, you now say, okay, I know that when people think that life is hopeless, they may also think about going to bed and not waking up. Have you thought about this? He says yes. You now go on to ask, because it's a spectrum from the thoughts to a plan. So have you ever planned about killing yourself? You say, okay, I've Googled, I've read in the internet how to die. It tells you the severity of intent. You have moved from the thoughts to a plan, which is reading the internet on the best way to die or where to procure an insecticide like sniper or something. So that degree of intent have moved, right? So before they're now committed. So the point is that we all have to be vigilant about it for our adolescents. It is good to look at the internet have become a useful resource to vent our frustration. So people go onto the internet before they die, maybe to say goodbye to their friend. If you get this type of abrupt goodbye, don't just take it for granted. Find out from this friend what is going on. The person may just be dropping a suicide note, right? So the person may even talk openly about suicide, but people will not take them serious. They may voice out a friend that they are going to kill themselves, but people will not, or they start dashing out their valued possessions. Maybe telling somebody to take care of their children. Just making some comment about departure. So this is the final preparation, right? So it is good to look out for the red signs, which is people who look for the risk factors, males, people who are using substances, people with depression, those with poor social support, and then people who have started voicing out their frustrations, their hopelessness, the desire to pass to the world beyond. These things are not casual thoughts. You have to investigate them to find out those who are truly on the path and those who are just making general comments. This is what we are all called to do. So if somebody have passed a message that you think this individual maybe, don't take off that your gut instinct. Just call this friend and ask what's going on with you. Because when this person dies, you say, he's a banker, he has everything. Why would he commit suicide? What do you mean? You really do not know. It's not about being a banker or being a doctor. Once you have the brain, you can oscillate into any of these, and these things can happen. So it is good to think about that. So suicide is very common. So what we just don't want is for the media to what they call sensationalization, like the reporting. You give details about every single thing, because there are many copycat people. There are people who don't know how to end their lives. So when you come to television and describe the full method, then thousands, like when they published the Third Mainland Bridge, it is the way the media carried it that many people now know, this is our final resting place. Mm-hmm. But the media can educate on the signs or the warning signs and all that, what community can do, but not give the full detail about the final act. If they do, many people who don't know will now go to the Third Mainland. So after the first Third Mainland Bridge, and when it was publicized, that's when you now see it. Those who don't know how to complete it now know the way to do it. So they head to Lagos and go and end up their life. So that's what the media can do for us. Yeah. But everybody have a duty to check on somebody who have just posted goodbye, the night is drawn, and then see you beyond. That comment is very crucial. You have to find out what is going on with this individual at that point in time. Thank you very much.
Dr. Onu, we have lots of requests for you to come back, and we will honor those requests. We'll schedule another meeting. But before, I think we need to wrap up. We still have people joining, so welcome if you're just joining us. I'm super excited, Dr. Onu and your team. Thank you so much for dedicating this time to helping Nigerians to get clarity and understanding about their mental health. You spoke about social media. The internet is here to stay, and we can see the advantages and the disadvantages of the internet. AI is the new thing, and everybody is diving into AI. We see people seeking solutions from chatbots, getting companions online, therapy apps and all. How do you think these mediums are realistic in terms of help? And what are their risks to us?
Okay, so, for everything that have its advantage, there are also some limitations. So I would say that the social media, they've come to stay, that the future, AI is the future, no doubt about that, yeah. But we also have to be cautious about how this impinge on our health. For example, we already know that screen time is a very important factor in cognitive development for children. So pediatricians will always cry and say, please, no child should spend more than 2 hours or 1 hour in a day watching the screen, because they tend to have the things they watch are fast-moving objects, tend them to be a little more hyperactive, their concentration is reduced and all that. So in fact, some pediatricians do argue that maybe the increase in neurodevelopmental problems like autism may not be far away from technological development that children are exposed to early in life. Then the social media is also like a space for loners. So people tend to have thousands of friends they never met. But that level of support is not in any way similar to the physical support system we used to have. Meet up with friends and gist. So thousands may stay in their room, have 100 friends, but they never had any physical contact. That the quality of friendship is not the same with the real one. We get to hang out, talk, and all that. So that's different. Then the internet, we can also get bullied, and it is asymmetrical. Of course, somebody can bully you at any time without you knowing, right? So because the person is just in your space. So cyberbullying is a real thing, and people get bullied and all that. So people also get. We had a patient that her trouble started from the internet, right? She had a connection with somebody in the internet and the social media, and they hooked up. And fortunately, that was the beginning of her ordeal, So she eventually came with post-traumatic stress disorder because she got into 4 guys. There was a rape situation, but the point of contact was, and the reason why she was a victim is because she was already socially disadvantaged in terms of she doesn't have a good relationship with people in real face-to-face. So her safe place was a place where she can't see you, right? So that was her safe place. So those people know the psychology of people who stay online and looking for friends. They may be socially awkward, that they cannot maintain physical kind of distance. So of course, it's not difficult to prey on you at that point in time. Now, people can also use social media, of course, the apps that can give you therapy and all that are useful, especially when your symptoms are mild. But of course, moderate to severe will still require a physician. There is no day that AI will completely take over the role of a physical. No matter how we do robotic surgery, we still need the human element to it. So we should know the limit of what we use those tools to. They can be good for educational purposes, and of course you should verify the content to be sure that the content is okay. So verify it. They can be used for educational, for information about where you can access help, basic psychological first aid for you. Now, but of course, if your symptoms are persisting, don't remain there. You have to get to see a clinician as appropriate. So good side, bad side, we just have to have a balance. Thank you.
Thank you so much. We are social beings. The internet that is why we have so much of the disorders, because everybody is trying to go indoors, but your brain, your system was built to socialize, to be among humans like you, not online. It gives you the fast dopamine satisfaction, but it's not taking us anywhere. There are also multiple cases internationally of people getting suicidal advice, getting procedures on how to take. There are lots of court cases, people, especially the young ones. So we should be very intentional. Screens are good, but being in the hands of those people that are not really aware or not supervised can actually lead to their demise. And we should also not dismiss the feelings of young people. I'm very particular about young people because I can see how withdrawn they are these days, especially teenagers trying to know their hormones, lots of change happening in their lives. They are quite withdrawn, and parents are busy. They are very busy. In your busy state as a parent, you should not ignore any signs. If your child is too quiet, there's a problem. We should try to listen to them. It's been a very long day. I did not expect this session to go this far, but I'm happy. I've learned a lot, and I'm sure you all have also learned a lot. Lastly, we'll talk about stigma. How can we help reduce stigma? Because we know lots of the families, they are being flagged. Don't go there. Don't go into that family. They all have one of their brother and their sister. How can we reduce this stigma?
All right, so thank you. Because we don't have time again, so I'll just take up the questions. But I also acknowledge my colleagues here too for that. So, well, first of all, we know that education is useful, but education is not everything. So getting to know, we now know that if you educate people about that this is not a spiritual attack, yeah, they will know, right? But would that change their behavior with regards to marrying or hiring them as their cook or something? That's the two different things. So people may know that, oh, this behavior is that of a mental, oh, you may have schizophrenia, you may have depression, go see a doctor. That's the first level. That's okay. As having education to know that these are symptoms of illness, not spiritual attack, is good. It helps to reduce stigma. But it does not necessarily change our attitude, which is basically, can I marry this person? So I did something with my medical students. So medical students come to me and stay with me for 4 weeks. So when they were coming in, I decided to give them a questionnaire to check their knowledge and attitude. So the knowledge is about what causes mental health. Then the attitude is whether they will hire somebody that has had mental health issues as a cook, date them, marry them. They're just personal things, Yeah, so they were going to learn psychiatry for 4 weeks, but they're also going to see people with mental health issues in the clinic. So I'm not giving education alone. I'm also doing what they call bringing them to have contact with them. So what I wanted them to do is that they will come and see in our clinic the richest man in Onitsha main market come to take his medication. Seeing that this man that is having millions had a mental health issues, he's taking his medication, he's well. Whether that will change their perspective beyond the knowledge that it is a medical problem, not a spiritual thing. So they came in, I gave them the questionnaire. So they learned psychiatry for 4 weeks. So when they come to clinic, they'll see a well-spoken lady, well-dressed, who is an accountant, just come to take her medicine, and she will go. So at the end of the posting, I gave them the same questionnaire again to see what has changed. Of course, knowledge improved dramatically. So people now know it's a medical condition. They can identify that it's genetics, that. But really, the behavior did not change. So whether they can hire them as a cook was still problematic. Whether they can, but there was there was an increment in those who can now accept them as friends, but not to marry them. But initially it was no. But now many of them will say, oh, they can be my friend actually, so, but I will not get to marry them, and many have accepted, oh, they could be my cook. After all, it can be controlled and all that. So in other words, the ways to deal with stigma are many. First, give education. 2, try to have contact, because contact will demystify the mystery. You normally think that these people are unpredictable, they are violent, but that's not true. People with mental health issues are not more violent than people from general population. You have gone to park to travel from maybe Asaba to, and then you get there, you tell somebody tell you pay 200 naira for your bag. You say you have 15, and you say God punish you. Unprovoked, he's cursing you from everywhere. That's verbal aggression. The person is not mentally ill. When you see someone with mental illness carrying a stick, you may think he wants to beat you, but he doesn't want to beat you. He's just protecting himself. Maybe people have been pouring him water as he's passing. So the stick is actually to scare people. So people who are not violent before they became ill are less likely to be violent even when they are ill. They tend to internalize those things within them. So there is not much difference between the general population and this. So it's only when you come in contact that you get to know. So don't stop somebody from working for you because your auntie had depression. No, it doesn't stop him from doing the work excellently. So that's when when people that have had mental health issues come to speak about it publicly. For example, renowned singers talked about their journey with drug abuse, how they got help, so the people know that these people are excellent. Governors who have had mental illness come up to say, oh, I suffered with schizophrenia, and still rule the state very well. Those things will begin to help people understand that this is not like a nihilism where you come to an end of you No, but it's just a condition like every other health condition that if well managed, the individual is able to pick up himself and continue with his activities of daily living. So these are the ways the society can help. So public education, trying to have contact with people, don't run away, because contact will dispel the ignorance you have. And then people that have had mental health issues, coming publicly to speak about it, their journey, how they got help, and how they are successful in life will help a lot. Yeah, thank you.
Yeah. Thank you, Doctor. The idea of celebrities coming out to tell us how they've struggled with one mental illness or the other, it's growing. It's growing, and they are also advising therapy. In Nigeria, I feel like no, therapy is for the white man. But gradually, celebrities are bringing out their voices, talking about it, encouraging people to actually go get professional help in terms of solving their mental illness. I was very intrigued during one of my courses. We did the study of Dr. Ellen Sachs. She's a professor. I think she's 70 or over 70 now. She has dealt with, she's been managing schizophrenia for a very long time, since she was a teenager, I think. But she's married, she's a professor, she's worked with the top universities, and she's still very okay, and she can ascribe her well-being and functioning to medical support she got, family support as well. The system we find ourselves is very important when it comes to recovery. I really want to take this moment to thank Dr. Onu, Temitope, Noma, and Obioma. Thank you very much for taking our time to give this intensive and insightful education. And we can't appreciate you enough. They say the reward for good work is more work. So we'll be calling you and your team to further educate us, because we have to call this session, call it to an end. If you're not in the community, I will advise you to join the community. We are also live on Instagram, the Mental Health Sentinel, on Facebook as well. We've had a very, very good conversation this evening. Before I leave, I also want to tell us that we need to put in those patterns that we want to play out in our lives and take away those other ones that are negative, harming us and leading us to further mental issues. So thank you so much. We know the economy is heavy. The stress is real. We're not going to pretend. We know that one, but our peace of mind is very important. It's non-negotiable. You can see that we have a shortage of medical help. Let's not overstress the help we have with more work. So those of us that are struggling to get away from substance, we encourage you to try as much as you can to help our society. We encourage you as well to seek professional help. We're trying as much as possible to build the awareness so the stigma drops. And let's just help each other, just be the light among people around you, and we'll be okay. We'll all be fine by the grace of God. So Dr. Onu, Dr. Temi, thank you so much for this impactful session. I would like to call it a night. See you all on the healthier side of tomorrow. Have a beautiful and restful night. God bless you. God bless you. I really appreciate this.
Yeah, thank you very much, Oghenevwiere. So thank you, Temi and Norma. Thank you for being there. And I don't know whether Dr. Koye joined, but we also thank her. She organized the whole team. So thank you so much. We look forward to being asked to come again. I will be there.
Sure, we will. We will. God bless you. Thank you.
Bye.
Good night.
Yeah. Good night. Yeah.